Chapter 25, the reproductive system, part 3. So, of course, hormones are very important for controlling what occurs in the ovaries and in the uterus and keeping them tied together so that when a fertilized egg cell makes it to the uterus is ready to allow for implantation. And these are referred to as the ovarian cycle and the uterine cycle. And the female reproductive cycle all begins, of course, with the brain, and specifically the hypothalamus. So the hypothalamus will release hormones, gonadotropic-releasing hormones that will go to the anterior pituitary gland, and this will cause it to release the follicle-stimulating hormone and the luteinizing hormone. So the way this works is the hypothalamus releases gonadotropin-releasing hormones, causing the release of the follicle-stimulating hormone by the anterior pituitary gland. It enters the bloodstream, travels to the ovaries, and initiates the development of the follicles. Follicle-stimulating hormone initiates the development of the follicle. As the follicle develops, it will itself start to release the hormones estrogen. And then, after becoming a mature follicle, the hypothalamus will cause the anterior pituitary gland to release high levels of luteinizing hormone. The high levels, the spike in amounts of luteinizing hormone in the bloodstream causes ovulation, triggers ovulation. And then the luteinizing hormone also stimulates the development of corpus luteum, which is important because corpus luteum produces the hormones progesterone and estrogen. And then, if there's no pregnancy, the corpus luteum will degrade down to scar tissue. So follicle-stimulating hormone causes the development, the stimulation and development of the follicles, and the luteinizing hormone causes ovulation and the development and persistence of the corpus luteum. So why do we need estrogen and progesterone? Well, initially, at the beginning of the uterine cycle and the beginning of the ovarian cycle, there's very low levels of estrogen in the bloodstream of the female. This leads to menstruation, the sloughing off of the functional layer of the endometrium. Then, as follicle-stimulating hormone causes follicles to develop, those follicles produce estrogen. And estrogen will stimulate the reformation, the development of the functional layer. So the functional layer will reform because of the estrogen produced by the follicles in the ovaries. After that, of course, ovulation, and then we have corpus luteum from the ovaries producing estrogens and progesterone. And this leads to the final development of the functional layer so that it is formed properly to allow for implantation to occur. And this is timed so that at the finishing of the development of the functional layer, the oocyte should have finally made it through the uterine tube and into the uterus. And of course, if it was fertilized, then implantation of the embryo can occur. So, menstrual phase is when the functional layer is sloughed off. Follicle-stimulating hormone is being produced to cause the follicle to develop. Low levels of estrogen. The functional layer sloughs off. Then the pre-ovulatory phase, this is when the follicle is producing just estrogen, reforming of the functional layer. Then we have ovulation occurring when there's a high level of luteinizing hormone present in the bloodstream. And then the post-ovulatory phase, this is when the uterus is fully developing because of the release of progesterone and estrogen. And these hormones are being produced by the corpus luteum, which exists because the luteinizing hormone allows it to. And then, after about 2 weeks or so, if no implantation occurs, then luteinizing hormones will drop down and corpus luteum will become scar tissue, and then there'll be very little levels of estrogen in the female's bloodstream, and so this will restart the menstrual phase. So again, no to low levels of estrogen is the trigger for the beginning of the uterine cycle for the menstruation. Then estrogen leads to the reformation of the functional layer, progesterone and estrogen, the final development and prep for implantation. If fertilization and implantation occurs, then the oocyte, actually by the time it reaches the uterus, if it was fertilized, will have divided and be a clump of cells, and the clump of cells will embed into the functional layer of the uterus. So the blastocyte, that's the official word for that ball of cells, will attach to the functional layer of the uterus and then embed into it, burrow into it. This leads to cells that will become the placenta and cells that will become the embryo. At this time, the embryo will be releasing the hormone human chorionic gonadotropin. And the function of human chorionic gonadotropin is to extend the life of corpus luteum for approximately 3 months. This means there'll be a continued production of progesterone, which will prevent the sloughing off of the functional layer. We do not want the functional layer to come off if there is an embryo implanted and developing. And it is this hormone, human chorionic gonadotropin, that is tested for in pregnancy tests because it is only present if there is an embryo implanted in the lining of the uterus. And then, of course, pregnancy occurs. As we can see, initially the uterus is pretty small, about the size of a female's fist, maybe a little smaller. Then as the embryo develops, the uterus will grow. No, the uterus does not stretch, it grows with the embryo and fetus, getting to a size eventually where it is actually directly below the xiphoid process of the sternum. And as you can imagine, lots of the organs in the abdominal and pelvic cavity have to be squished and pushed aside to make room for the developing fetus. And of course, there's childbirth. Initially, the fetus will position itself so that the head is now pointed toward the vagina. This is not how it normally is. It will shift position when it gets time for childbirth to occur. Then we have early dilation, the widening of the cervix. Then the cervix will continue to widen until it is wide enough that the head of the infant can start to pass through the cervix and enter the vagina. The expulsion, the movement of the infant through the vagina and out of the female's body. And then finally, the placental stage, when the placenta is also ejected out of the female because it's not needed anymore. All right, sometimes people do not want to have a pregnancy to occur, and there are a variety of approaches for contraception, for prevention of pregnancy. There are ineffective methods like coitus interruptus, where the male removes his penis and ejaculates outside of the female's body. There's the rhythm method, where the female sort of keeps track of when her menstruation is, and basically in certain periods of that in the month, it will be less likely that she would become pregnant if she has a sex, and then so only has sex during those periods of the month. Chemical barriers, usually spermicides, poisons against the sperm, creams, foams, jellies, by themselves not very effective. However, in combination with mechanical barriers, such as the male or female condoms, diaphragm, and the cervical cap, they are able to function much better. Mechanical barriers are pretty effective, 90% or so effective, as long as they're used properly. There's a cervical cap, and a diaphragm. Very effective is combined hormone contraceptives. This is things like the pill, chemical rings or patches, oral contraceptives, the pill, injection of hormones. Basically, the woman is taking hormones like progesterone and estrogen specifically to trick the body into thinking that she's pregnant, and so doesn't release the oocyte. And then, of course, another device is the intrauterine device. It is placed by a medical professional into the uterus, causes the lining of the uterus to become inflamed, thereby preventing implantation, and also it is toxic to sperm. The most effective, next to abstinence, is sterilization via surgical methods, such as vasectomy, where the ductus deferens are cut and ligated, thereby preventing the sperm from leaving the scrotum, and therefore when the male ejaculates, no sperm will be released. And then on a female case, tubal ligation, where the uterine tubes are cut and ligated, thereby preventing the oocyte from making it to the uterus. Surgical methods, 99.99% effective, but not 100% effective, as my neighbors found out when they had twins unexpectedly. And that is it for this lecture.